collaboration. This has been a common theme I've noticed myself across many of the presentations. So hopefully I'm going to focus on highlighting some from our own experience. There are a couple of slides in here where I invite audience participation because I don't think anyone really wants to hear from me for now an hour. So if you will please feel free to share your own experiences, and hopefully there'll be something that's a little bit different, some nuggets that you can take home from this session that you'll find useful in your own work. So first of all, as mentioned, Care Alliance we're a healthcare for the homeless grantee and a public housing primary care. Our mission is rooted in our commitment to serving the poorest of the poor. We're sort of a non-traditional health center, as you'll see in the next couple of slides that follow. We're often referred to in Cleveland as the safety net of the safety net. Our brief history, we were one of the original Robert Wood Johnson demonstration sites for healthcare for the homeless, and started there. We became an independent nonprofit in '93 and added public housing primary care in '98. And originally we added the PHPC so that we could maintain our existing patients as they got housed. But I'm going to go into more of how our outreach into the public housing areas in Cleveland has become more and more a part of our growth and expansion strategy. And then just a couple of our other, we have Ryan White now, both Part A and Part C. We added dental in 2002 and that actually has some of our most long-term providers. We have some of the same folks that started the dental program are still there today. And that actually we've got 4 times the amount of demand and capacity in our dental program. We added our electronic medical record in 2012, and we went with Epic, which is great in Cleveland given the hospital systems the majority of the hospital systems are on Epic, and so it allows for sharing of data with patient consent and has really helped enhance the care coordination that we're able to do for our patients. Just in January of 2013, we received level 3 PCMH recognition, which was who's been through that likely has the similar binder as I do sitting on my bookshelf. It's about yay thick. And we see this just given our patient population, this was a really big undertaking for us, and we're really proud to be able to say that, to count ourselves among the very few homeless and public housing organizations that have this designation. And then just in February, we implemented our EDR, Dentrix, which fully is integrated with Epic, and so again allows us to kind of maintain the electronic sharing of data for our patients. In 2012, we provided care to roughly almost just shy of 10,000 patients. We like to add this up or enhance this a bit through more than 35,000 encounters. The basic demographics, as I said, were often referred to as the safety net of the safety net. So as you'll see, 79% are completely uninsured, with 94% living below 100% of FPL. So if you've been in a session with me where they've talked about Medicaid expansion, I've really pushed this because the exchanges are great, but Ohio right now is counted in one of those no or maybe states, and as you'll see, almost all of our patients would qualify for Medicaid given Medicaid expansion. So that's on the one hand, but then on the other hand, we have traditionally been more of, whereas we're dropping below the 60-40 split, we've been more 70-30, and as we've seen more of our patients living in public housing, we've really wanted to make sure that we're more strategic about how we reach our public housing folks, and also moving into where there's more of a traditional Medicaid population, and so we wouldn't be as reliant on Medicaid expansion, on grant funding, et cetera. Our clinics, we've got 3 standalone clinics at this moment. Our downtown clinic is on a main thoroughfare in Cleveland, and it's located closest to the largest homeless shelters in the city. We have our men's shelter sleeps 400 a night, so we have a really large homeless presence, and so our downtown clinic primarily serves the homeless. We have 2, I've highlighted these given the public housing focus. We have 2 clinics, one on the east side, one on the west side. Just a side note, if you know anything about Cleveland, the city sits in the middle, and then there's an east side and the west side, and you don't cross. I'm not from Cleveland originally. I'm from Atlanta, and this was foreign to me. Like, but it's just right over there. But they really don't cross. And so having a presence on the east side and the west side is really important. So we have our East Side Clinic is located in a public housing social service mall with a number of other organizations providing care and services to public housing residents. There are 296 total units in the immediate area with 174 units in the building. Our West Side Clinic is in Riverview Towers, which has 490 units in the towers themselves and then 8 nearby family units. And then we have given our impetus is more of a healthcare for the homeless organization. We have a series of outreach clinics. We have a number of outreach clinics that are in shelters, transitional housing, et cetera. And so we've always adopted the, go to where your patients are. And we've done a really great job of doing that with the homeless. And that's now what we're trying to do that more and more with our public housing patients instead of just saying, okay, we've got a clinic here, we've got a clinic there, that covers everyone. Not so, which likely comes as no surprise. I will say that in our Riverview Towers, there's an increasing number of homeless on the near west side, and so that has become a clinic that serves both public housing and homeless, which is a little bit unique. I think traditionally, you get more families and children when you're serving public housing, and so and we're doing a renovation of that clinic right now, and so that has been important to keep in mind as we renovate that clinic. This is a map of Cleveland with Lake Erie, right? Some people call us the mistake by the lake. I've lived there 10 years. I try not to, I may have thought that when I first moved, but however, it grows on you as a city. But all of our locations are highlighted by the green is actually our outreach locations. This is St. Clair, so this is our main site. I guess I could use the pointer. I'm not always so proficient with these. That's St. Clair right there. So that's kind of our flagship site, and then everything branches off from that. Our services are designed to be comprehensive in nature, and they really do now obviously try to perpetuate the PCMH model of care. And there's a heavy reliance on our supportive services side and on care coordination primarily of ensuring that we're doing a good job of maintaining a team of folks that surround our patients and ensuring that they receive the right care at the right time, at the right place, that takes care of all of their needs. There's been a lot of talk, obviously, across of the unique health needs that we see in all of our patient population. I've highlighted, this is a combination of what we see across our patients, so this will include some that are more primarily homeless and public housing. But one of the reasons why I really like this slide is because you often see, obviously, that this is one of those kind of cyclical slides where the barriers to care often lead to or perpetuate a heightened risk for poor health and vice versa. And so we sort of, all of our goals is to try and really help our patients not stay here. Here is our funding slide. We have a $6.2 million annual operating budget in FY13. We're primarily funded by HRSA and then followed by the United Way and other local foundations. We've received quite a bit of United Way funding. Our expenses are for first and foremost in patient care. We have very small, the green, the 12% represents management and general expenses. So we really feel strongly that all of our funding goes right back into what we do. Our expenses are aligned with our programs. So partnering for our patients. This is a slide that tries to capture, this is not exhaustive, but it tries to capture our main partners that we have. Collaboration is at the core of what we do. It always has been because we recognize that we can't be all things to all people. And so really trying to make sure that we can provide the appropriate care to our patients, be that internally or be that through collaborative and referral relationships externally. We've tried of late to really have, it doesn't look that way here, but really should have few but very deep collaboration so that we can cross and just that they're quick and fast acting and you're not kind of waiting for movement between the two. There are going to be 3 of these that I'm going to focus on today. The public housing side of the homeless and public housing collaborations, physical and behavioral health integration, and then workforce development. So as I mentioned, this slide captures what's really guiding our growth and expansion efforts, and I would just highlight at the bottom where I say that there's a focus on public housing and permanent supportive housing. We're really trying to increase our penetration in the public housing market in town as that's what we're there to do. And so we're trying to apply some of the strategies that have been more reserved for our homeless outreach and street outreach and going to where our patients are and recognizing that in Cleveland, as I imagine, is very similar to other cities, our public housing, they're neighborhood units, and folks like to stay in their neighborhoods. And so to assume that just because you have one on the east side and one on the west side, you're going to capture all public housing patients that live on the east side and live on the west side, those days are not, I don't know that those days ever existed, and they're certainly gone. So really trying to make sure that we are expanding and improving access among our public housing patients and really going to where they can find us and where they want to find us. So the Cuyahoga Metropolitan Housing Authority, CMHA, is the housing authority that we have worked with since 1993. We have long partnered on clinic space. We have long partnered to address the needs of our residents together, and then we really do try through our partnerships to affect neighborhood revitalization and to ensure that we are positively contributing to the neighborhood as well and doing so together. These stats are those that are related to CMHA. It was chartered in 1933 and is one of the first housing authorities in the U.S. It's one of the 10 largest. And this sort of captures, so now they serve 55,000 people in Cleveland. So fairly large. This slide captures what primarily the main tenets of our partnership with them. I'm so pleased and we're so thankful every day to be able to say that they provide us free rent and utilities for all of our existing clinics. We often share, we're the owners, and we end up sharing the health data of residents, and then we often get the income data. You know, there's a lot of sharing of data of residents, a lot of letters of support written for grants and providing information back and forth that goes on. And there's been a lot, not only of the leadership and the organizational recognition that exists as we've honored them, they have honored us. You know, we tend to be at the annual meetings of each other, but we really try and make sure that that is carried out not only from the top-down approach, but from the bottom-up approach as well, and really ensuring that at every level of staff that there's a relationship that exists. And I'll go more into that in the future. And then on our renovation and construction, which I'm going to talk about, for our Riverview towers, we just these are within weeks that we just negotiated with them, 25-year rent-free lease with the option to renew at 20 years. We don't start paying utilities until the 18th year, and then we have a negotiated rate moving forward. For our brand new clinic that we'll be building in Central, which I'll talk about in a moment, we were given a 99-year ground lease for a $10 nominal fee. So I think that really speaks to the relationship that we have, that after all these years, the majority of the folks that are in the social service mall, for example, pay rent, and we don't. So I think that there's a recognition on both sides of the benefit of our relationship, and we're able to capture that from a monetary perspective as well. So as I mentioned, public housing has been a focus of our growth and expansion. We were fortunate to receive 2 capital grants from HRSA in the last round of funding last May. We received $5 million to build a new state-of-the-art 30,000 square foot clinic in the Central neighborhood, which I'll go into more detail and keeps all of us up at night. And then a $500,000 grant to renovate the Riverview clinic. So this is a picture of Riverview Towers. It's actually located across the street. It's about a mile down from our county hospital, and it's across the street from one of the Cleveland Clinic hospitals that primarily they have a fairly busy, not Metro is the busiest emergency department, but they have a fairly busy emergency department at Lutheran, and they have a lot of their psych services are available at that hospital, and so that's been an important collaborative. I didn't focus in on our collaborations with the hospital systems, but where Riverview is concerned, and we're trying to do a lot of better triaging in the emergency departments of patients, and identifying high ED utilizers of our own. We've actually placed a community health worker in Metro to try and redirect, I never want to use the word divert, redirect patients into the appropriate setting for care. So the proximity of the hospital systems has been very beneficial for us. But we will be expanding what was a 2-day-a-week medical-only clinic into a 5-day-a-week medical and dental clinic. So we previously we had 4 medical exam rooms. We'll have 5 medical exam rooms and 2 dental suites, which will have 4 dental chairs. There is no dental care aside from at the county hospital on the near west side. So this will be huge for the community to bring dental services directly into their backyard. And we've already been working out a relationship with, there's a 330E FQHC that's on the near west side that primarily takes care of the working poor, and we're working out a relationship where we can provide the dental services for their patients, which we're excited about. They have more Medicaid patients than we do. So we see that at the end of this, you'll see we serve roughly 500 patients now, and we'll be able to see almost 4,000 and when we're at full capacity. We're in the middle of renovation right now. It actually should be complete. We should complete the project within 12 weeks. And so our target open date is August 5th, which is quickly approaching. And we're very excited, and so in the process of hiring folks and doing all of those sorts of things. But as I mentioned, the relationship with CMHA has been key here, because by not needing to worry about rent, that frees up other operational dollars that don't come with the capital funding to then try and expand a clinic and serve more folks. So we didn't need to worry about budgeting for any of the traditional, what other organizations might see, given the commitment and relationship that we have with the Housing Authority. Our central clinic construction, this is a rendition of what it will look like. It sits on a very busy intersection in the heart of the central neighborhood, which is where the highest concentration of public housing is in the city of Cleveland. There is no, limited, I will say. There is a hospital there. They don't like it when I say there's no primary care, but there's very, very limited primary care in the central neighborhood right now. There's a high number of women and children, and the hospital that is there is a Catholic hospital, and so they really haven't been able to serve the needs of the community given their mission. And so what we've seen, and anyone who talks about Central or knows about Central, we say, you know, they're at the bottom of every list you want to be on the top of, and they're on the top of every list you want to be on the bottom of. So we're building a 30,000 square foot facility to serve 13,000 patients annually. Our target completion date is May 2015. That's when we have to be done per our grant. We're planning to open our doors in the fall of 2014. But given Cleveland winters, given anything that comes with construction, you know, we tend to put that date up there. This is when it has to be open. So Central, just quickly a little bit about Central by the numbers. 40% of the residents are younger than 18 years old, as we said. This is women and children. This is really children having children. And there's no prenatal care. There's no women's health. There's very few. What happens is that the babies are delivered in the hospitals and that's in the local hospital system, and that's it. There's 0 pediatricians. We saw with a recent study done by one of our neighborhood partners, a 25% increased likelihood of all over the city rate that residents would use hospital care. As I mentioned, there's one hospital that's sort of on the borders, St. Vincent's, and it is a phenomenal hospital system, or hospital. And then a third of the residents used emergency room for non-emergent care in the last year. And as I mentioned, there are 0 family planning services available in Central. As I said, Central is the highest concentration of public housing in the city. 75% in the neighborhood are in public housing. When we originally went after the capital development grant, we did so with the intent to replace our East Side clinic. We were going to, which is in another public housing area, not as big as Central, and we were going to build a freestanding clinic near where our existing clinic is, close that clinic and move services there. And we kind of figured we'd catch everybody, like I said, because those facilities are a mile apart, different neighborhoods. we were asked by the mayor, and this is in Central, there's a Promise Neighborhood Coalition. They've gone after, if you're aware of the education grant, the Promise grant, which was modeled after Dr. Jeffrey Canada, and it's all the money that has come down through Department of Education to primarily focus on education and social services. They've gone after it 3 times and they've missed it, but there's a very busy collaborative that actually Sisters of Charity, of which St. Vincent's is a hospital, where they focus there, and they're very active. And then it's also a choice neighborhood. So CMHA received the HUD choice grants to really raise a number of the public housing units and rebuild. And so we were asked by the mayor and by Sisters of Charity to relocate to this corner to be in the heart of the Central neighborhood and really serve folks that aren't being served now. And we were excited to be asked. We're excited to be a part of it. We think that will actually help us as from the perspective of, we all know if you build it, they don't just come. But really trying to do targeted outreach right now to raise awareness of who we are, because a lot of people don't know who we are, and we know that. But to start early and rely on our partners to try to drive some of that. This slide just captures again where we would be before and then where we would be after for all of our sites. So I'll skip over that. But I think from the perspective of lessons learned of working with our housing authority, and this first one is sort of carries through to all of our partnerships. It's important to establish that shared vision and the shared language so that you know you're on the same page and you're working towards the same thing. As I mentioned, it's been essential that we work with all levels of the organization so that we have that we know firsthand from residents that we have experience and relationships with we call them AMPs, the area management folks, but the resident recommendations that are some more building specific versus kind of the corporate CMHA level. We have found there's a family self-sufficiency program that exists that primarily focuses on housing and social services, and we have a strong referral relationship between those two, our own kind of enrollment and eligibility specialists in the FSS program, so that we can try and work together on some of those. And this last one, I just put, again, don't take for granted the need to market and for clear signage and direct outreach, because again, just because you're there, and there might be, I mean, we've sat around with residents and I've had my badge on there. Where are you from? I said, oh, from Carolina. What's that again? I'm like, you're standing underneath our sign. So, of just making sure that you take the time to spend time in there so that you're known. I think that we've seen that in our penetration rates as they've started to increase, if we've done more targeted outreach and haven't just taken for granted that if we were there, people will use us. So I don't know if anybody wants to add some of their own tidbits of working with housing authorities, or if you're from a housing authority, of working with the PHPC Health Center or other health centers. Or I think it's called, yes. Oh. Sure. Yes. Both. So we have in the largest homeless, so for the men's shelter, for example, that I mentioned, that has 400 beds, that sleeps 400, we have a permanent space, and we're not there 5 days a week. So that's not, someone actually is there 5 days a week, but we have a physician and an MA that goes 2 days a week, full 2 days. And it's gotten to the point, our medical director would like to make that a continuity clinic, and it's pretty close to getting that way, which on the one hand is sort of scary. But I think, so, and then in some instances, we have an outreach cycle of where folks go. We always take, if we're doing actual primary care in the setting, we do try to have space. Some of the outreach, we have a space in a building called the Storefront where a lot of folks come. And that started where there was no exam table, there was a couch. And that's, so we sort of make do with the space that we're given. Some of them actually look like real clinics. Others of it is we're in a room, we're given a room, we take our own outreach supplies, and we function that way. We have an outreach team that's led by an RN, But then our providers that rotate through. So we've got a provider that always goes to the women's shelter. We have a provider that always goes to the men's shelter, et cetera. And we've tried. This is where I would say we've needed to be a little bit creative in how we implement the PCMH model of care, because you try to maintain that team approach, and we at least try to maintain that between the provider, which can be an MD, an NP, or a PA, and an MA. And then in some instances we have LPNs, so we really, our outreach team has a number of LPNs that primarily do health education, screening, and teachings. So. Mm-hmm. Yeah, we've done that. Mm-hmm. Mm-hmm. And we treat those more as episodic and, trying more from a stabilization approach. The ultimate goal of our outreach team is really that we can get folks to the position where they would prefer to receive care in a more traditional setting. But that doesn't always happen. And we've got folks that are regular patients that live in campsites. And the outreach team they go to campsites and visit and deliver care that way. So, this can go from just delivering basic care of toothbrushes or socks, sleeping bags, suntan lotion. There's a lot of outreach in the wintertime, obviously, to try and really get folks off the streets and into the shelters, just, again, given the 6-month Cleveland winters that we have. But so we've ended up, and I can't say enough about our outreach team has been together for a really long time. That was how we started. They've really got sort of the street outreach down, and then really figuring out how to make use of space and still deliver quality care in the space setting. But a lot of it is episodic, and a lot of it is, really trying to get a sense of what's going on right then and there. So from stabilization. So from a scope of practice, so we have, I'm trying to think of how we do that. So we've got the clinics where we have a more permanent presence. Those are listed within our scope. So the men's shelter, for example, is a site within our scope. And then we have more of like the outreach team is kind, and the outreach services listed as a scope, because they don't always stay the same, and they don't necessarily, from one week to the next, because so it ends up looking a little bit like a mobile van. You had a question? Or not? Mhm. 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 I think that, again, for us, it was stressing that once, if you've been primarily homeless, it's sort of stressing the more, if part of what we're doing is helping to contribute to income stabilization, and we're trying to get folks housed, which is absolutely part of when you're a healthcare for the homeless provider. There's so much, this is where you really think big H and social deterrent, because there's so much of our outreach team primarily that really functions as a social service agency. And in some instances, this is where those referral relationships to housing become that much more important. So if you're seeing enough of your folks kind of follow on the path of becoming stabilized and moving into public housing, which is what you would hope you would see, then there's one argument. I won't say that part of the driving force for growth and expansion is so that we can continue serving the homeless. And ideally balance the books on more traditional Medicaid so that, or Medicaid expansion that are primarily you see more of in public housing. So there is a financial benefit directly to your bottom line that you can have there. I don't know that I'd rush to do capital, I think just in this day and age, because I think one of the ways that we've struggled, I'll be honest, it's been great to get $5.5 million from the federal government to build new buildings, but that doesn't come with operating funds. And so for any of us that are and that changes that very much our development approach in the last year. We go after a lot of local funding, and that they're huge contributors to our operating budget and to our operating line. Well, I can't go to them for their traditional annual operating request and to help us build the buildings at the same, and for bricks and mortar. And so that's been challenging on trying to budget and grow and do all of that at a time. So we started from where I tried first to kind of have our outreach team, who's always been homeless oriented. You're the outreach team for all of our patients, and all of our patients include public housing. And so to try and start setting up some sort of presence, and if you've got the time to have a nurse practitioner and a MA, that's what we found. You can break even if we've got a nurse practitioner and an MA delivering care. And I'll get to this. This is how we've done a lot of our integration projects. Is that if I'm trying to think, in each state, obviously this would be different given what your PPS rate and all those sorts of things. But for a nurse practitioner and an MA to go in for an 8-hour day of clinic, if you see 15 patients, roughly half of those need to be Medicaid to break even for that day. So there are ways in which you can try to sort of pilot some projects that they may have more of a taste of while you work to sort of prove your case. Mm-hmm. Yeah. Yeah. I don't know. Mm-hmm. Yeah, bricks and mortar. Yeah. You'll have to see. I think some of that might depend on what kind of a relationship and what kind of a deal you could work out with the public housing. Like if they're willing to give you some space for a little bit, and maybe maybe the carrot becomes the capital project. So, it's a little bit of, well, if we could, let's see how this goes. Let me do a better job of serving your patients right where they are. And then with the long-term plan, even if it's a year or 2 years. I think we don't know. They did, obviously HRSA just did the last round of huge capital development. So we'll have to see, and now we're sort of praying for the service expansion dollars to follow, expanded medical capacity. I'm like, come on. So when Sean Frick says we're advocating for, expanding current, then that benefits. That's what we're working for. Yeah. All right. So integrated care. I should do a time check here. 11:30. So there's been a lot of talk throughout this conference, obviously, of the need to integrate behavioral health and physical health, and just the higher prevalence, the higher incidence of behavioral health issues that we see in a public housing, that we see among the public housing population. And so this has really been driving a lot of what we've done. What I'll say that I found the most interesting, I joined Care Alliance a year ago, and I worked at the Cleveland Clinic for 8 years prior to that, and I'm a public health person. And one of the things that as I moved into this field that I found really interesting is that I think that, and this is anecdotal, and so you can disagree with this, but from my own perspective, I found that there seemed to be really solid integration of behavioral health, mental health, and housing. And it was like all of a sudden, oh, we should really have primary care here too. And maybe because I came from more of a primary care focus, that seemed more obvious to me. And this maybe is just Cleveland, but a number of our homeless shelters, a number of the permanent supportive housing, a number of the public housing have a heavy presence of behavioral health and case management and organizations that either come in or in some instances, the behavioral health organizations are responsible for those housing units. But primary care is like new to them to be like, oh, you guys should come, you guys should come. And Ohio has to control the state Medicaid budget. They're really pushing for integration within the behavioral health location. So they're changing the payment models within behavioral health care to push for coordination to include primary care. So we're sort of driven by that as well. But why we do this is that 2 of every 5 Caroline's patients has a behavioral health issue, and there's a real shortage, and we have a real trouble of getting our patients to get behavioral health care. Because there does seem to be some sort of, just due to funding and due to the way that things are run, there seems to be a light switch that exists at behavioral health organizations of, today I can see uninsured patients, tomorrow I can't. Today, that seems, and it's not necessarily due to mission, and it's not necessarily due to commitment. It all has to do with funding. It all has to do with funding. And so this has been an area that I've spent a lot of time in the last couple of years, of really trying to ensure that not only do we have behavioral health care on site for Caroline's patients, but then also looking at the best behavioral health partners where we can be the primary care provider. So we have 3 partners right now that we focus on. The Centers for Families and Children is the largest behavioral health, community behavioral health organization in Cleveland. We are in one of their buildings, and we have an NP and an MA that goes 2 days a week to program. We have integrated, we've done cross-training where their folks are trained on Epic and our folks are trained on their behavioral health record, to just ensure that there really is truly integrated care. Because that's one of the things, and I'll say this in my slide, that I think I would say is one of the biggest limiting factors to actually achieving integration. You can do a really great job of getting co-location, but until you can integrate the record, and that is a huge feat. So again, we just have access to each other's. It's not like you can pull up one record and it has everything there. Our physicians have to flip back and forth, and their folks have to flip back and forth, but at least you can get a more complete recognition of what's going on with a patient. But our focus in their one building is on public housing. So the building that we're in primarily serves low-income public housing residents, and so that's been our focus there. Mental health services, actually since putting this presentation together, changed their name to Frontline Services. So that should say Frontline Services. And they have been a long-time partner of ours. They're the homeless behavioral health organization. And so what we have long been doing joint care consulting on patients, common patients. We have a SAMHSA grant, Bridges to Housing, that looks at integrating, adding the housing integration in there, where we focus on chronically homeless and providing primary care, case management, behavioral health care services, as well as getting them housed. So we've been working with that. Our plan now is we're trying to establish a clinic in their main flagship site, which is actually really just a couple blocks away from ours. And then we also went after some grant funding for a mobile clinic where we'd be able to serve the permanent supportive housing. And they primarily are they primarily manage the permanent supportive housing buildings in Cleveland. And then Beachbrook is a children and adolescent youth organization. They started as an orphanage. They have been in business for like over 100 years. They're a phenomenal organization, and we were already co-located with them at our East Side clinic on the same floor down the hall. So now we're working at doing, doing a better job. We've got a set day where we share patients, and you have one point of registration, and so that you kind of come into one place. And the way that we approach integration is more from the patient perspective, because again, as I said, there are aspects of integration that I think just given from an organizational perspective can be very hard to achieve. But what we try to do is from a patient perspective, they should never know who's helping them. So as far as they're concerned, if they are more knowledgeable of Beachbrook, then they think they're seeing a Beachbrook provider. You know, it's just more of that ease of moving through the system and receiving both your primary care and your behavioral health care at the same location, and in best instances on the same day. That's what we try to do. So our lessons learned here have been, again, it's important to establish a shared vision and a shared language. Even from the very basic, we refer to folks that we serve as patients, and our behavioral health partners refer to folks that they serve as clients. So it's even just establishing at the basic level of who you're serving. And that it is, you know, it's known, it's been proven, we all know this, that it's more comprehensive, it's more complete, and it's more efficient when you can get there. It's important to establish a multidisciplinary team and include all levels of that. So from the front desk all the way through your physician or your psychiatrist, so that everybody sort of knows what's going on. And what we've really found is that no-show rates or things like that are improved when the behavioral health case manager is the one that's really at the core of that team. So we have care coordinators, but when we're talking about being on site, whomever knows the patient or client the best is the one that we've found can directly contribute to sort of ensuring that folks are there. As I mentioned previously, integrate the health record, electronic health record, to the best of your ability so folks have all the information in front of them. And then the last one, again, we've got 3 partners, and the way that each of those, the way that the clinic is structured, the way that the partnership is structured, it looks different for each one of those. And so that model varies, and it's constantly evolving. In our instance, a lot of that is driven by the state, which is telling the community behavioral health organizations how they have to be structured and how they're going to be reimbursed. So there's a lot of moving parts and pieces to this, at least in Cleveland and in Ohio as a whole. I meant to have one of those slides in there that says your own experience. So I don't know if any of you have anything, either questions or if there's anything that you'd like to add from an integration perspective. We on the behavioral health team, they are. Yes, so they have them implemented. In a lot of instances, we just sort of add our primary care team to their existing team and sort of fit right into what they're doing. So I'm not as knowledgeable on some of the nitty-gritty details on the behavioral health side. But I know, again, from whether they be lay workers, peer mentors, or the traditional case managers, that's been a lot of what's driven seeking primary care to begin with, and sort of trusting the service, as it's been new for a lot of them. I will also say that at the centers, they ran their wellness program around peer. They really used peer mentors and how they spread wellness across their organization. I want to say yes. I want to say they were. Yeah. Yeah. Yeah, and that's how we've got a lot of care, community health workers and care workers that have done the same thing on that side. We have one, in the traditional sense of the definition, we have one community health worker, but then we have a number of care coordinators and a number of that, and now thanks to what will be, because we've been funding our outreach and enrollment specialists, we have our county hospital they applied for and received a Medicaid 1115 waiver, which means that you can you can essentially function as Medicaid expansion today as you would in a year. So that's given us a lot of experience, and that's how we've been able to hire more folks. But we've got the one community health worker that's primarily focused on attaching herself to the homeless outreach program and into the emergency room. So, but we are hoping to do more and more of that. I would love to see more training opportunities. I don't know if you guys feel that way, but I think that if there could be more training that's specific to the FQHC world, I think we'd be better served for that. So on the, just very quickly, I'm sure a number of the health centers here have a number of relationships with academic centers where you try and get, at varying degrees, training programs on site to help sort of enhance your staff. We received a grant from one of our local foundations to start to prepare Care Alliance to become a teaching health center, which means that we would have our own residency program in the future. There's some funding that's sort of loosely defined that would be set aside for community health centers in ACA. It hasn't been released yet. There was one round that came, and the folks that received, the health centers that received it really were already functioning at that level. So we were fortunate enough to receive a grant, and we partnered with the Department of Family Medicine at Case Western University, which is attached to University Hospital System, to start to try to move towards that way. To see where we can go. And so we see this it's a little bit of our more traditional training volunteer programs on steroids in a way. So we have 3 phases of this that we're trying to follow. The first phase was to certify Care Alliance as a family medicine center of the existing residency program. The second phase is to establish a standalone residency program. Again, all of these it'd be a residency program of cases. It would just be based at Care Alliance. And then the third phase, and this is highly dependent on funding from the federal government, would be to designate Care Alliance as a teaching health center. So we are still in this first phase, and what I'll say is that we actually did submit an application to the residency review committee to try and do just this. I was having a conversation with someone at the reception a couple nights ago. Given again our patient demographics, we don't have a lot of kids and we don't have a lot of seniors because our patients, frankly, don't live that long. And so when they came down to be family medicine, you have to, and as a health center in general, obviously we're all committed to serving from cradle to grave. As a family medicine residency program, however, there are real percentages that you have to meet so that the trainees are the medical learners are able to actually have experience, not only, with every aspect of the population. And we were not, while they said, we love what you're doing, this is great, keep it up, you got to get more elderly patients, you got to get more kids before we can improve this. And so, I think there have been interesting challenges that have come about from this partnership, some just in the very nature of who we are and thinking that perhaps a very bureaucratic organization is actually going to consider who your patient population is. Not so much. But, really being able to ensure that we're able to provide the services not only for our patients that benefit, but for the medical learners as well. So that's been sort of a different approach. But because we have the funding, the local funding, we're still able to ensure that the family medicine residents come over to Care Alliance and see our patients. Continuity of care has been another issue. University hospitals they have a how do I want to say this? It's not necessarily the hospital that we first and foremost refer our patients to. It's not as easy to make those referrals to university hospitals. So that's been something that they've needed to really work on. If family medicine wants this to be a priority, then they have to make sure that they're able to have our patients be included in the continuity clinics that the residents need to maintain as a part of their learning requirements. So while this list is short, I think, we keep finding ourselves up on this last one. And what I would say from the, kind of benefit side of this, it's been really important that we keep our eye on the prize. There are a lot of times where I walk away from meetings or I walk away from a phone call of some kind and I say, okay, but this is just helping ensure that we can become a teaching health center. So this is one of those collaborations where you really need to keep your eye on the end goal. And it may not necessarily feel beneficial day in and day out to what you're doing, probably on both sides. And there are many challenges that come from the resident requirements that I think we knew, but even until you get into the nitty-gritty, you don't really know. But having good partners, we've got a physician that has a dual appointment, and that's been really helpful. So she has been involved in their residency program for years and years and years, and even was the program coordinator, whatever they're called, for there. And so she has a lot of knowledge about all of the criteria and such that's needed for the residency program. And then she also knows a lot about us. And so that has been really helpful to have somebody that can wear both hats. See, I remembered here. So I don't know if there's anything that you guys, I don't know. I mean, I know a number of community health centers really rely on having trainees and residents, and then other, nurse practitioners and folks in training to come in. I don't know if there are other folks that are already a teaching health center or are working to be a teaching health center. Anything you think you could share? Are you? That's good. Congratulations. Other questions there? So the last part, to kind of come back to the tools for effective collaboration. As mentioned, I am currently pursuing my doctorate in public health. And as a part of that, you have to do a little thing called a dissertation, which has just been lovely, and I have tons of free time for. But what I myself am doing, I'm focusing on the local implement strategic plans, namely looking at Opening Doors, which is the national strategic plan to end homelessness, through the eyes of the HCH program. So if you're familiar with Opening Doors, there's a lot of housing there. And they say there's a lot of health care if you read through it all. But there's no defined role for the HCH program, which is a hugely federally funded program that you think would have a roadmap as it relates to a national strategic plan to end homelessness. And so that's what I am focusing on. And so one of the things that I included in this is to kind of run through the literature review that's attached here, because it sort of underscores some of the academic literature that exists. None of this is rocket science. This was an instance where, frankly, I was pleased to see the academic literature sort of align with practical experience, because I think there are times where that exists and times where that doesn't. So I looked at characteristics of successful local community partnerships or collaborations that are responsible for implementing national strategies or federal strategic plans. My goal was to identify a framework of factors or characteristics that were must-haves. If you're going to do collaboration, what do you need to have? Now, I think we all could probably have a list of what you think you need to have. Just sort of spoiler alert, it doesn't look that different from what you think. But, again, academics, you got to run through the exercise. It's a chapter. And so my inclusion criteria was I looked at peer-reviewed journal articles since 2000. They needed to focus on a health topic. I defined health with a big H. Again, think social determinants of health, think the positive aspects of health, not the negative aspects. WHO definition is really the what I applied from a focus on a health topic. They needed to discuss a national plan or a national strategy that was being implemented, and they needed to outline, there needed to actually be a list of. We found that these factors and these characteristics contributed to our success, or on the flip side of that, these prohibited success. These were the barriers that we needed to get around as we moved through. The key concepts of partnerships and collaborations in the national strategies and federal strategic plans needed to be expanded past their sort of traditional definitions to sort of capture on the partnership or collaboration side just some sort of local entity that was focused on a health, it's formal in a way, but I didn't necessarily define formal, but a formal in name or in recognition group that's working together. So more than one group, more than one person. It couldn't just be one organization. It needed to be two or more. And then national strategies or federal strategic plans really needed to be, you were addressing a public health issue of national significance. So you were working on tobacco. You were working on, it really could be broad from that perspective, but local coalition focused on health issue is what it ended up being, not necessarily trying to carry out Healthy People 2020. in those. So they needed to expand so that I'd have a broader reach in the literature. This is the very academic slide of how I arrived at the 7 articles. These were the search terms, how I got there. Sort of boring from a practice perspective. So there were 7 articles that were included. 1 focused on HIT, 3 of them focused on behavioral health, and 3 of them focused on coalition work in general. And likely as no surprise, the 3 that focused on the coalition work in general, I found to be the most useful and to really, from a strength of study perspective, to really have the best information that could be transferable, not only to all of healthcare, but then also to opening doors specifically. So what I did was I extracted that were in each of the 7 articles. I then looked to see where they crossed those articles. So that's the middle column, and then I categorized them. And I categorized them based on function for the most part, either because it often came up through the literature review process, or it was sort of a more traditionally known strategic planning function. And so I arrived at this framework, which, as I said, should not look that strange to you. That in order to be successful, that these were sort of catch-all categories that as a coalition you needed to do. And it could, if you're doing coalition work, you could look at, do we have leadership? Do we have purpose and commitment, communication, accountability, etc.? And that would at least suggest that you have a better chance of success. Important to note, this has by no means been tested. This is by no means, but I've been doing partnership and collaboration work for my entire career. And I will say again that if you had asked me in the beginning, would they have been those terms? Maybe not. But from the perspective of what's important to have, these, I think, would be on most folks' list. And so from a leadership perspective, it's important to have a defined leader, someone who's knowledgeable of the cause and who can really rally the crowd, both internally and externally. Purpose and commitment is both the mission and the vision, and the ability for folks to have commitment towards that mission and vision, but it also captures that for each individual organization, the benefits of being a part of that group outweigh the costs that affect their own individual organization. Communication needs to be clear, needs to be concise, needs to be consistent. It needs to be internal and external. There needs to be a sense of folks in the community know what you're doing as well, so that you're established as a subject matter expert. Accountability goes that you feel accountable to the mission and the purpose of that group, and so you feel accountable to stay a member, but it also captures the need to have defined roles for your leadership, defined roles for the individual partners, defined roles for the community in some instances. So it's sort of the roles and responsibilities that exist in coalition work. The funding and the resources is how you're going to do the work, and then the planning and operations is what is the work. So again, I don't know, I'd like to think that if you sat and put together your own framework, again, it might not have those words there, and it's likely that there's something missing. I tried to establish these sort of catch-all terms where if you came up with something, even if it took me a minute, I could figure out a way that it fit into that category. Now, mainly that was because I had to defend this. So, I think from an academic exercise perspective that was more important. But I think that from our own organization, we've enjoyed sort of looking at some of those collaborations that we have. And I can certainly come up with those that have been successful. I can come up with those that haven't. And I think, I was able, and really when I was preparing for the defense, to sort of think through why that was, why that wasn't. So I don't know if there are any questions there, but that sort of concludes. It concludes. Our medical director loves this, so I like to include it on the cartoon. I very much feel that way on any given day. So, but thank you. I think that, and why it was on each of the slides, I found really ensuring that there was a common language across that we all were committed to was so important. That pretty consistent across everything that I've done, of ensuring, you know, the common language, the mission, of just some of the more obvious things that you may think are there, but when you actually have a conversation around them, what I think might have been different from what our partners thought. And so making sure that you start at the same place. And then you sort of lead into the more tactical challenges of the blending of the EMR, or of the trying to figure out, you know, what the RRC really wants to see, you know, some of the more tactical challenges that exist from bringing together two organizations. But I would say that kind of across the board, it's that common language. Usually the commitment is there, and in some sense the vision may be the same. Oh, sure. The vision may be the same, but I think, you know, really making sure that at the ground level and at the higher levels, everybody's on the same page. Sure. So we've done, and it varies given kind of the outreach that we're doing and why we're doing it. One of the things that we've done with the waiver program, that's sort of to set us up for kind of to set us up where we feel like we're doing a lot in the outreach and enrollment and making some learnings there, is that we did a lot of targeted outreach in our public housing, not only just where our clinics were, but in all, really working with all of the LAC, you know, kind of the community groups that exist at each of the buildings, going in. We did door hangers. We made door hangers and hung them on every door. Now, what's been interesting is that we have found that we've reached more new patients that way than reach existing patients that we already have an established relationship with and are likely to generate, you know, the 3 encounters, which then means that you're actually generating some income from signing folks up. So that's been interesting to us. And then just consistently being there. I think there's a lot about, you know, just presence. And presence at all levels of, you know, my boss, our chief executive officer, he walks in, he walks through the doors, he knows the area managers, you know, and so it's not just me, or it's not just our staff that do the outreach and enrollment or do the targeted direct outreach. It's at all levels where, you know, we have a commitment to being there, and we have a commitment to being known and listening. And so really just sort of making the time to not keep it at that surface organizational level, where you have we have a partnership with CMHA and it's done, and so therefore we're there. But really taking the time to ensure that your relationship is more than just one person and is more than just at that leadership level, is on the ground. Because I think what I've found anyway is that the on-the-ground relationships are often more important than the leadership level. So the hospital, Cleveland's an interesting town because there are 3 FQHCs, there are 2 free clinics, then there are 4 hospital systems. And I would say everybody has varying degrees of relationships across one another. A couple of years ago, there was, I would say a couple of years ago was way more, I will say on the hospital side of things, it was way more competitive, except for the Cleveland Clinic, who will tell you that their competitors are Hopkins. And again, they're a part of me that still has the Kool-Aid. I was there a long time. So there's a little bit of the ivory tower bit with the clinic, though they do have more under Dr. Cosgrove, who's the CEO now. He's been more committed to the local community than really any other CEO. So there's been more of an effort of the clinic to get involved. The county hospital and the Catholic hospital have always had that community presence. University hospitals is also sort of a different, like they try to play with the clinic and compete against the clinic, and then they also try to maintain like a local presence, and I think sometimes they struggle with doing both because they don't necessarily know where to put their efforts and their energies. And so our organization has long referred and had long-time referral relationships with St. Vincent's and with Metro, because that's where the majority of our patients go, often in some instances to seek care. So, and that's where we end up referring them. So there's long been that. from a getting everybody on the same page, a couple of years ago, Cleveland was, the county was run by county commissioners. It's now was voted out because you may have seen that one of them, the feds came in and one of them was very corrupt and I believe is now in jail. So there's, a little bit of corruption that went on with county government, as you might see. But that one of the county commissioners brought everybody together, literally everybody together in the same room, was basically like, you are a disgrace to the community, start working together. They gave money to our county HHS, and one of the local foundations gave some additional money to bring in a consultant to start an access plan. So it was really around the growing uninsured issue. And they said they put us all in a room and were like, you guys figure this out. And that has helped. I think, the competition, the safety net, what I've always found amazing about our safety net providers is that everybody has their niche. We serve public housing and we serve homeless. And there's a lot of, and people sort of let us do that. On the Near West Side, the 330E, the geography breaks that up, but then also the patient population does. And there's not a lot of crossing across the free clinics and the FQHCs, and there's long been a good relationship because I think there are enough people, and we've all got capacity issues. And so if there was competition among the safety net, then the community really would not be in a great spot. And so that was very refreshing when I sort of moved over, was sort of the just collaboration that exists. I think that, on the moving into Central, for the Catholic hospital, they sort of recognized that they couldn't serve the community the way that they needed to be served, and we're there to take care of public housing. And so it was sort of an easy marriage, if you will. Thank you. Thanks.